Awesome. That was fantastic, Laura. It's always exciting to hear what's going on at the Runway program at HRSA. Next, I'd like to introduce a fascinating speaker, Judith Currier, who's going to talk about new investigational ART drugs and strategies. Briefly about Dr. Currier, she's professor of medicine and the Division of Infectious Diseases in the Department of Medicine at UCLA, Center for Clinical AIDS Research and Education. Dr. Currier is trained in both ID and clinical epidemiology, and I've followed her for years as her research interests really included treatment and prevention of complications of ART, gender-related issues in HIV therapy, and the evaluation of antiretroviral treatment strategies in resource-limited settings. Really excited to hear her talk today. Take it over.
Thank you so much. It's really great to be here. Greetings from Los Angeles. I'm going to talk about new drugs today. I have no disclosures to report, and I'm going to try to focus on helping learners be able to name 2 drugs that are currently in development and describe how they might be used in the future. I decided to focus on new drugs in the horizon that are in new classes and really on some of the data that's been presented in the last year. There's really been a lot, so it's exciting, and I think it's good to know what's coming. And as we just heard about ending the epidemic, while I don't think a pill is going to end the epidemic, I think that some of these longer acting drugs may play a really important role combined with other measures. So we'll talk about that. So let's dive into the horizon of long-acting treatments. First of all is Islatravir, and this is a nucleoside reverse transcriptase translocation inhibitor. So that it has 2 different ways that it stops HIV replication. It first prevents the opening of the RT nucleotide binding site, and then it also, after that change, prevents incorporation of new nucleotides. So it's thought to have a high barrier to resistance. It's being evaluated both for treatment and for prevention, and it as a single tablet formulation with doravirine, as it's made by Merck. It has a long half-life, 128 hours, an intracellular half-life of the active triphosphate. And it's being evaluated dosed daily, once weekly, once monthly, and then even longer, potentially as an implant. So lots of different ways of thinking about the use of this drug. So what's the data to date that's new in the past year? So in this P011 study, they looked at 3 different doses of Islatravir combined with doravirine 3TC. And then among those who were suppressed after the first 24 weeks, they reduced it to 2 drug combinations and then went on to a maintenance phase with the 0.75 milligram combined just doravirine. And these were combined or compared to the standard treatment of doravirine, 3TC, and TDF. So this was in treatment naive people who had no evidence of resistance and obviously no active Hep B because of the 2 drug combination. The key findings were that serious adverse events were very rare and nobody stopped because of safety, but headache and diarrhea were most commonly reported. Looking here at other notable safety concerns, triglyceride elevations were uncommon, as were liver enzymes. CK elevations were usually attributed to exercise and were reversible. So it appeared safe in combination with doravirine. And then efficacy at 96 weeks was presented both at the Glasgow conference last year and looking out to 96 weeks at the viral suppression rates. You can see that the 0.75 milligram dose with doravirine, about 90% were less than 50 copies. And that was comparable to the control group. And all of the Islatravir doses combined together was about 81%. So good viral efficacy with this combination. So there's several different other studies going on that in treatment naive and heavily experienced, and also in people who are currently virally suppressed, switching to other regimens. And importantly, studies in children and adolescents are also planned. As of this time, I'm not aware of any work going on in pregnancy. I think the interesting thing about this is it can be dosed in different ways, and finding partners to dose it with for long-acting combinations is going to be interesting. I'll talk a little bit more about that in a second. So one of those partners might be Lenacapavir. This is a capsid inhibitor that prevents both nuclear assembly, virus assembly and release, and capsid assembly. So it works kind of in two different points, in the beginning and the end of the viral replication cycle. What's nice about this new mechanism of action is that it is drugs or viruses that are resistant to all the other classes should retain susceptibility to this. And then the really exciting thing is the half-life. The oral half-life is 12 days, and the subcutaneous formulation has a half-life of about 175 days. And so it can be given every 6 months, which is really groundbreaking in terms of the frequency of dosing. So in terms of studies, we'll start with the Capella study. And this is a study, the first evidence of activity, and they started in people who had heavily multi-drug resistant, basically HIV. And they had to have resistance to 2 or more agents. And there are 2 parts of the study, one group that went into a randomized comparison, and I'm going to focus on that at the top of the slide. So the people in this study, first, they entered the study, they were failing their current regimen. They got either oral lenacapavir with the failing regimen or placebo, and then only for 14 days. And this is a new design that really allows us the opportunity to see the activity of drugs quickly without exposing people for longer periods of time. Then all of the participants were switched to the sub-Q formulation. In the first group, Q 6 months. In the second group, they got the oral for 14 days, and then they went on the Q 6-month lenacapavir. There was another group that just went straight into the lenacapavir with optimized background that also just contribute to the safety database and some of the activity database. But the primary endpoint, 90% of those in the lenacapavir group achieved more than a half a log reduction in the first 14 days compared to 17% in the placebo group. So clearly there was activity. Looking now at the groups overall, just the baseline characteristics of the study, they did enroll a fairly diverse population. And you can see, I think what really struck me about this is the median time since HIV diagnosis was 24 years in this group, and 11 overall, 11 prior antiretroviral drugs that the people had been on. So this was a really heavily treatment experienced population. So how did it do? So these are all 36 of the participants summarized here together, looking at the viral reduction, and you can see that less than 50 copies was achieved in 81% and less than 200 in 89%. Also, depending on the number of fully active agents, you would expect to potentially see some difference, but even those who had no other fully active agents, 67% became less than 50 copies. It was 86% on those who had 1 and 81% in those who had 2 or more. Importantly, for people who had low CD4 count at entry, the median change was 81 cells, and a significant proportion who had a low CD4 count, less than 50, went from 22% to 0%. So it was able to bring people out from below 50 cells, which is really something we haven't had many opportunities to do with too many agents recently. So, but there's a little bit of a concern here with respect to resistance. And 4 patients did have emergent lenacapavir resistance. They all remained on the drug. 3 were able to return to being suppressed at a later visit. 2 without and 1 with optimization of the background regimen, and 1 never received full suppression. What was also notable, though, is that none of the patients developed resistance to the other drugs in their optimized background. But the barrier to resistance for this drug may not be significant, super high, I guess I would say. It was well tolerated. I think we worry the safety of injectables is always an issue, and whether there'll be problems with injection site reactions. More than half had an injection site reaction, but most of them were very mild, and none of the patients refused a second injection because of concerns about the safety. The other adverse events are shown on the slide, and you can see that there was sort of a smattering of the most common types of adverse events. So nothing new really popped out. Now, with this study showing this efficacy, high rate of viral suppression, the increase in CD4 count of 81 cells, and being well tolerated, this really suggests that this will potentially have a role both for heavily treatment experienced, and then obviously of interest is how will this do in people who are treatment naive. So let's go on and talk about what we know about that population. And that brings us to the Calibrate study. So this is Lenacapavir in treatment naive patients. And the study design is a little complicated, but I really do congratulate the designers of this for trying to do multiple things at the same time. So let me just walk you through this. These are people who are treatment naive and have a CD4 count above 200. They were randomized into 4 groups, and the first 2 groups received the sub-Q Lenacapavir with FTC and TAF, oral FTC and TAF. And then if they were less than 50 copies at week 28, they went on to a maintenance regimen, either with Lenacapavir and TAF or Lenacapavir and Bictegravir. These were compared to a group who stayed on the oral formulation of Lenacapavir with FTC and TAF, or a standard initial regimen of Bictegravir, FTC, and TAF. So there's a lot going on there in the study design. The median age was 29, 93% were men, 52% were Black, and 45% Latinx ethnicity. And the primary outcome was looking at viral load of less than 50 at week 54. So here are the results, and you can see that the groups, all of the groups did well with respect to viral suppression. However, there was a participant in the Lenacapavir sub-Q with FTC TAF who developed resistance at week 10. Interestingly, this participant did have drug levels that were thought to be in the therapeutic range. So again, suggesting that there may be a resistance barrier may not be as high for this drug. The adverse events in the study was, again, well tolerated, no SAEs or grade 4 related to the drug. About 39% reported an injection site reaction. And interestingly, in this group, there were 2 who discontinued due to ISRs. And I think that just shows that if you're in the setting of being treatment experienced with few options, and you develop this reaction, your willingness to continue might be different than if you're treatment naive. Other adverse events, nausea in the sub-Q versus oral, 12 versus 8%, and diarrhea around 6 to 8%. So generally it was well tolerated. On the right, you can see the types of and the incidence of injection site reactions and how long they lasted for the participants. So I'm actually going to go back for a second. So before I go on then to talk about the next drug, I think that these data suggest that Lenacapavir will have a role in treatment. And I think the pairing of this together with potentially with Islatravir in treatment experienced patients and potentially looking at long-acting combinations, these 2 in the long-acting formulations will be interesting to see, although their dosing intervals are different. I'll talk about some other pairings in a minute. Before that, I want to just turn to the maturation inhibitors, which is another new class of drugs. These we've heard about before, and they prevent proteolytic cleavage of specific portions of the GAG protein, which then prevents the processing of the GAG pol polyprotein late in the stage of HIV replication. And Berevermet, which was a maturation inhibitor in development, did not progress because of pre-existing mutations at this cleavage site, and that was unfortunate. So this new formulation is thought to have, a higher barrier to resistance. And its first study was done in the first sort of proof of concept was presented at Currier this past year. And they chose to study this in treatment naive people and started out with a 10-day study to just look at this as a monotherapy with a plan to quickly move to combination therapy after having a chance to see the virologic activity. Well, they quickly recognized that resistance was happening at this day 10 period. So switched the study then to part 2, where the period of monotherapy was reduced to 7 days and expanded the dosing cohorts that were evaluated. So putting the data together from these 2 cohorts, I would say here they failed to enroll a diverse sample in their population. They were all treatment naive, however, with a median viral load around 4.25 logs at entry. Looking at their rates of the antiviral activity, you could see that it was very potent in the first part of the study, the 200 milligram dose. And the second part of the study, where the treatment duration was a little bit shorter, you'd see the antiviral activity of each of the doses compared to placebo. So definitely demonstrating that this new compound has antiviral activity in treatment naive participants. And this resistance that developed, though, was in 4 of the 6 people who received it in the 10-day monotherapy component of the study. But interestingly, there was no resistance developed in part 2 of the study when it was given only for 7 days. So this, I think, suggests that when it's used as a part of combination therapy, we may see good results. So this is just good to see this drug moving forward in development. And I believe it will be looked at with other NRTIs. So about a 1.5 log reduction with the 140 milligram once daily dose and 2 logs with the 200, well tolerated. There were no grade 3 or 4 AEs, and they will be moving on. All right, so just a second to talk about broadly neutralizing antibodies. So this is really an exciting new area of development. I think we've seen with COVID that role of passive immune therapy has a lot of potential. These are antibodies directed against conserved epitopes that are now several are in long-acting formulations and being commercialized. And I think there's some exciting ways of thinking about how they might be used as treatment. Some of the approaches, so long-acting cabotegravir with the broadly neutralizing antibody is one way that this is being studied in an AIDS clinical trials group study. Is a single-arm trial of long-acting cabotegravir with the VRC07LS as a maintenance therapy. That study is in the field, so I don't have any data yet. Another trial is looking at 2 of these long-acting antibodies together, where people who are suppressed on a current regimen will switch to the antibodies alone, given infrequently. And then just to say there are other drugs in this class that are in development, including a tri-specific antibody, which is being looked at in a phase 1 study. Gilead is also doing a phase 1 study looking at the antibody that they've acquired for commercialization, otherwise previously known as 3BNC117LS, in people who previously had virologic suppression. So these studies are really starting to hit the field, and hopefully next year we'll have some results on how this works in the clinic. And I want to kind of spend the last few minutes talking about investigational approaches with the drugs that we have in the clinic today, long-acting cabotegravir and rilpivirine. So these were approved for use in people who are virologically suppressed and no prior resistance, to be given in an every 4-week dosing schedule. So this was really the first utilization, or the efficacy had been shown the best in this group. In Europe, the Q8-week dosing has been approved, but not yet in the US. They're approved both in the oral formulation of cabotegravir of 30 milligrams in rilpivirine and in the sustained release after this oral lead-in. The Atlas 2M study has compared the 4 and 8 week dosing in people who have been suppressed on the 4-week dosing. And the follow-up results of that were presented this year, just showing reassuringly that this 8-week dosing appears to be non-inferior to the Q4-week dosing. And I think we all recognize that less frequent dosing will be more desirable for patients. Very few injection site reactions. Importantly, the MOCA trial from the Impact Network is also evaluating this in adolescents, looking at both the Q4 and Q8 week dosing. And those results are really anticipated. So we have this drug now, but it's really only approved for use in people who are virologically suppressed. And as we think about ending the epidemic, what's the value of these drugs and for people who've had challenges with prior virologic suppression? I want to just mention the Latitude study, which is currently in the field, which is really trying to address this question and answer whether it is achievable for people who have previously been unsuppressed. So the study design is a little complicated, and I'll just walk you through it, but people who have been out of care or unsuppressed who have options for treatment based on resistance will enter the study and have a 3-drug regimen designed and provided. Now, in addition to that, they will have adherence support, and they'll receive economic incentives for achieving different benchmarks in viral suppression. And so the idea is if they can get suppressed on an oral regimen, would a long-acting treatment help keep them in care and suppressed? So they'll be randomized then to long-acting cabotegravir, whoops, went too fast, or stay on the standard of care. And after 52 weeks, have the opportunity to go into the long-acting arm. Achieving this initial viral suppression may turn out to be a challenge greater than we can meet, but I think it's worth a try. And this will see really what the role of this long-acting combination might be, and then whether it could also later be switched to every 8 weeks. So I think the study is, and the results of this are really anticipated. Now, I think the other approach that people are thinking about for those who are out of care and not suppressed is, are there ways to go directly to a long-acting regimen that will help them retain suppression while they transition back into care? And now we have some of the drugs, available to start thinking about how we might do that. And it's exciting to see really what the potential might be for long-acting treatment in this population. So I just like to summarize a lot of new data, in the last year on new drugs with novel mechanisms and less frequent dosing. And they're making their way through development. Islatravir, Lenacapavir, this maturation inhibitor, GSK254, and then several broadly neutralizing antibodies that can be given potentially every 6 months are also being studied. We're learning more about how the long-acting drugs that have been approved for use in virally suppressed populations might be utilized to achieve suppression in people who have previously not been suppressed once they get suppressed, and also whether the 8-week dosing regimens will work. There have been a lot of challenges to the implementation of long-acting treatment in the clinic setting, and I think this is a topic that will probably be discussed more in this meeting. It's one thing to have a drug that can be given less frequently, but it's another to have a way of delivering it. And I think that more, we certainly need more efforts to understand how to make these treatments available when they are approved. So I look forward to answering your questions, and thank you for your attention on this Sunday afternoon. So I will stop there.
All righty, I'm trying to get back on video. That's a great talk, Judy. Really appreciate you going through the landscape of what's happening and what's coming. There are several questions in the Q&A already, and And one, I'll start with one just for clarification about use of rilpivirine, injectable rilpivirine, and that's, can you use the PPI, any proton pump inhibitors with injectable rilpivirine?
Yeah, that's a great question. I think that you can, but I think that you can because it's not given it's not given orally at the same time as the drug. But I would double check that. But I don't think it's got the same limitation that the oral formulation has.
That's my understanding, but I always say check with our friendly pharmacist to make sure we're not wrong. There's another question, again, more of clarification by Chikinwachuku, was lenacapavir used as a single regimen treatment, and doesn't it change the purpose if patient still has to continue taking oral regimens with it? Which I think it's a great question.
Yeah, it is really kind of one of the things I was getting at sort of indirectly. Is great that you have one drug that can be given sub-Q every 6 months, but if the only partners that it has available to it have to be given every day, is that going to really work? And don't we really need combinations that can be given every 6 months? So I think these are the kinds of things that are going to be tested, in the studies that are going on. And really, what's the tolerance, right? Could you give a 6 monthly drug with a once a month drug, or does everything really just have to be the same? I mean, hopefully we'll get to the point where we will have these, what we think about sort of symmetric regimens where they are given at the same frequency. But I do share your concern that if you still have to take one pill every day, this every 6 month thing isn't going to, change the tide here. Because I think people either take all of their meds or none of their meds, and often this missing just one isn't really the pattern of non-adherence that we see.
Yeah, I think it's a really great question and comment, because I think, we see the challenges when we had 3 agents people had to get to the pharmacy, and there were multiple different, renewal patterns, et cetera. And then one pills changed that, right? You got your whole regimen at once. And so you do wonder about that. Are we changing things much if you still have to go to the clinic once a month for your shot and still have to get your pills? How do you work into people's lives? It's a really great question.
Yeah, and one other thing about that is also, you said, and you have to go to the clinic to get your shot. We do have to figure out like where you're going to get your shot, because if the drug, is a sub-Q or IM formulation, and you don't have a pharmacy at your site, or the person has to go get their drug somewhere and bring it there, we are making it more complicated. So where this is all happening, I think, is another really important conversation.
Right. And, as part of that conversation, if anybody's been through fertility, agents doing a lot of that at home. And will we get to the point where you can simplify even further, where somebody can just do their shot at home? And would that change things as well? So I think lots of things in terms of delivery. I know our clinic is struggling with how to get people, what the schedule looks like, who's going to do it, resources, particularly when our workforce is stretched and strapped and burnt out, like Laura pointed out. Dr. Barrett asked, any idea when the FDA will approve Q8 cabrylpivirine?
I don't know. I think there are some things. I think it's certainly, I've heard people say that it will be evaluated by January, but I don't think we can promise. The FDA is under incredible stress right now, and their antiviral division with all the COVID drugs they're looking at. I don't even know, it may be different people, but I think, hopefully it will be soon, but I don't know.
Right. No, I heard the same. It's nice that we at least have the data. I think in 2017, which is the adolescent, they're doing a Q8, and having adolescents at our site, they're ecstatic about just coming in and having their whole regimen every 8 weeks. I do think it makes a difference. Some specific questions. Would you feel comfortable using long-acting cabrylpivirine in patients with a history of 184V, 103N, no other mutations, who really, really want this injectable form and chronically suppressed on oral ART for you?
Yeah, I mean, I think we're talking about off-label use of a drug based on how it was approved for. I think the approval specifically says people without prior resistance, but I, certainly wouldn't be worried about 184 in being a problem for the response to it. So I think that is, if you are confident that that's all they have. I think sometimes, the issue is when somebody has some NRTI resistance, if they aren't on the NNRTI at the time that you measure the resistance, are we sure that they, that that's not all that's there? So I guess I would be a little bit careful about that, but 184 via M184V, I wouldn't be concerned about.
No, I agree. And I think that gets the question of cumulative resistance, and is what we see, what we get in terms of digging down and making sure we know what's been there, a threat of being there in the past. And there are a couple of questions. I have one myself about the whole non-adherent folks and the need for oral lead-in. There were, some discussion about, rapid start or patients who are struggling to get in care, and you get them in clinic. Do we actually need the oral lead-in, or can we get that shot in arm as soon as we can when they're a captive audience? And what data is there for that? And do we think we'd get to that point where we don't?
Yeah, there was a direct to inject arm in, I believe, the Atlas study, and it does appear that that you can go directly to injection. But again, that's in a population who's previously been fully suppressed on ART. And I think we cannot extrapolate the efficacy from a virally suppressed group to people who've been out of care or have a history of resistance on previous regimens. So that's really I think the thing that we have to be very careful about is extrapolating to other populations that were not included in the original studies. But I do think that direct to inject will be something that we can use potentially in people who are naive to treatment rather than in the fully suppressed or out of care with unknown prior resistance.
Yeah. I think that's the challenge with Latitude. I think it's a great study looking at individuals who are non-adherent, but getting those individuals who've been non-adherent to get 6 months or longer, it's almost impossible, right? So I think that's a challenge of actually trying to study it in the population, and I think it's going to lead to people kind of just doing it because they don't have any other way to get this individual. So yeah. Hopefully that data.
They are going to shorten the first part of the study. It's being amended to shorten that period because of the challenges of, and just sort of also the interest in having to do it for that long, and the necessity, I think, is the other issue. It's really essential that you be suppressed for that long. So that is the amendment to the study that is coming soon. So I agree, but it's true that if you have to get if you have to be suppressed on a daily oral treatment, or if only those who can be suppressed on a daily treatment are able to take the long acting, we're going to exclude a huge group of people who can't be suppressed on daily oral treatment. So we need other strategies for them.
Right. And there's a few other questions they're rolling in. Thank you everybody for being so active in the Q&A. The oral lead-in piece was also relevant to individuals who have strictures or other reasons why they cannot actually take a pill. So I think that's not just a non-adherent and challenge, but also people who just cannot get the pill down, which I think is a good question. Are there other drugs like ibalizumab in development, to your knowledge?
Yeah, there are other drugs. This is by no means a extensive list of all the drugs in development. There's certainly many other drugs that are in development besides the one I talked about. And I do want to go back to that issue that was, there are some people who can't take pills or who have this, have the reasons they can't take pills or have this emotional reaction to taking pills, where I think that we may, direct to inject might be the best route for those individuals. It's just hard to make broad recommendations for it, but there certainly are people who just can't take pills.
Yeah, no, I agree. I take care of a lot of perinatally acquired individuals, and it's amazing how there literally is an aversion to medicine. It's just, I cannot put the pill in my mouth. It reminds me of so much negativity around that pill. And so thinking about how we can change that, whether it's an injection, an implant, something else to get people where they are. We have about 40 seconds. Maybe we can get one more in. I think an important one, CAB is PrEP. And there'll be some on this, and maybe any word on CAB on PrEP, maybe, and other of these injectables for PrEP, maybe you can
Yeah, I think Dr. Landovitz might be talking
He
about
is.
that later, and he knows more about that than anybody in the world. So yes, I think we're going to hear more about that. And thank you,
Awesome.
Jen Kaiser, for confirming that you can take the PPI with IM. And she says she's going to talk more about that too.
Awesome. No, I stick around. We have 11 seconds, so we're going to end. But you know, what you all are highlighting a lot of the questions. In the questions, we're going to have many presentations. So I guess we're good on in terms of developing the program. So many of these will be addressed during the conference. Right now, we're going to take a 20-minute break. Keep the questions rolling in with the sessions. It's been great so far.
Thank you.
Thank you, Judy.